In medicine, some mysteries are physical, but others are psychological, and Munchausen Syndrome, now called Factitious Disorder Imposed on Self, is one of the most perplexing. Unlike most patients who seek relief, those with this disorder secretly create or exaggerate symptoms, driven by a need for attention and care. The name comes from Baron Munchausen, a fictional storyteller hinting at the element of fabrication at the heart of the disorder. This isn't about faking illness for money or drugs, that's malingering. Here, the motivation is internal, a deep psychological need to be seen as sick. The person may not even understand why they do it, but the emotional void is real. Medical professionals often feel betrayed when they discover the truth, as the trust at the core of healthcare is exploited. Yet it's crucial to see these individuals not as malicious deceivers, but as people suffering from a severe mental illness. Their elaborate deceptions are symptoms, not character flaws. Understanding this distinction is the first step toward compassion and effective care. Munchausen syndrome challenges us to look beyond frustration and see the profound human struggle beneath the surface. It's a call for empathy, not judgment. Only then can we begin to help. People with factitious disorder imposed on self often present convincing, dramatic symptoms, headaches, pain, fainting, that are hard to disprove. They're often well-versed in medical jargon, making their stories believable to doctors and nurses. But it goes beyond faking. Some will harm themselves, inject bacteria, or tamper with tests to create real signs of illness. Hospital hopping is common. When suspicion arises, they move on, leaving a trail of confusing medical histories. The motivation isn't money or drugs, but a powerful need to be cared for and to feel special. The hospital becomes a stage where they're the center of attention, receiving validation missing from their daily lives. This risky behavior can lead to real medical harm, but the emotional payoff outweighs the danger for them. Their identity as a patient gives them purpose and structure. It's a desperate attempt to fill an emotional void. The cycle is hard to break. The roots of Munchausen syndrome often lie in childhood trauma, abuse, neglect, or emotional deprivation. For some, being sick was the only time they received care, creating a lasting link between illness and love. Others spent long periods in hospitals for real illnesses, finding comfort and identity in the patient role. When that's gone, they may feel lost, unable to cope with normal life. Low self-worth and fragile identity are common. Dramatic medical crises become a way to feel important and valued. The attention from doctors and nurses temporarily boosts their self-esteem. Some may also have underlying personality disorders, adding to the instability and need for attention. The fabricated illness is a coping mechanism for overwhelming emotional pain. It's not about manipulation, but survival. Understanding this helps us respond with empathy, not anger. Munchausen, by proxy, now called factitious disorder imposed on another, is even more disturbing. Here, a caregiver, often a parent, induces or fabricates illness in someone vulnerable, usually a child. The caregiver, not the victim, has the disorder, seeking attention and sympathy through the suffering of another. This is a form of abuse, not a cry for help. Victims endure unnecessary medical procedures and trauma, while the perpetrator appears devoted and caring. The deception is hard to detect. Caregivers often charm medical staff and seem tireless in their devotion. Recognition requires vigilance. Unexplained symptoms, failed treatments, or improvement when the caregiver is absent are red flags. This is a medical emergency and a child protection issue. Suspected cases must be reported immediately to protect the victim. The consequences are devastating, both physically and psychologically. It's a stark reminder of how psychological needs can cause real harm to others. Diagnosing factitious disorder is challenging. There's no test, only patterns of deception and inconsistent medical histories. Doctors must rule out real illness, collaborate across hospitals, and look for clues like eagerness for invasive procedures. Confrontation rarely works, patients often deny and disappear, restarting the cycle elsewhere. The real goal is to guide them towards psychiatric care using a non-confrontational, empathetic approach. Psychotherapy, especially cognitive behavioral therapy, is the main treatment, helping patients understand and manage their emotional needs. Family therapy can also help rebuild healthier relationships and support systems. Recovery is slow and difficult, but possible with patience and compassion. It's vital for both professionals and the public to approach this disorder with empathy, not condemnation. These are people in deep pain, not villains. If you suspect someone is struggling, encourage them to seek mental health support. With the right care, healing is possible.